looking at how can we just accomplish joint movement in each one of these regions, and then in areas where I'm going to start saying it's safe and efficient to go to some stretching. So there's going to be some factors like making sure you have a stabilizing hand. Example being, if I'm going to try to assess the knee, I want to make sure I fix the stuff above it so that when I move this, I'm feeling just the knee move. If I don't have a stabilizing hand, then like stuff could shift in such a way. So I want to always be stabilizing, usually proximal to what I'm assessing. So proximal versus distal, proximal's closer to the torso, distal's further away. So I want to be usually stabilizing proximal and then just bending, seeing what my end range is. The ideal ranges for the knees are, we know we need to get to 90 plus. As long as we get to a good 90 plus, that's enough for functional range. Ideal range would be 125. So this is a good example of not too shabby. If it was less than that, and one thing I can also watch for, and she's not going to show it, if the hips are particularly tight, if the hips are particularly tight, if I were to take this knee to end range, I might see their pelvis start to pick up because the hip flexors, as they also, the quads, the top one, since it works at the hip and the knee, you can do this and now pick up. Anyway, let's look at this and how it would reflect in a session. So how could I do some basic mobility of the lumbar vertebrae? Right here. If I can just get the pelvis rocking back and forth, we're causing little tiny rotations of the lumbar vertebrae. And then I can feel, so my hand is ideally kind of more or less right in the sacrum. I'm making sure my fingers are picked up. So it's just like my palm as a wedge there on the sacrum and just at the top edge of the sacrum. Usually it's just so easy to find. Find where the low back starts to become a hill, plant your hand there, make sure it's central with the spine, and then move back and forth. Now, does it feel like it's easier to move the pelvis in one direction versus another? Like here, pretty symmetrical. Maybe it feels a little bit harder for me to shift it to the left than it is to the right. Okay? One thing I'm watching for here too is as I do this, as I move the pelvis and everything below it back and forth, and the lumbar vertebrae are having to allow some rotation for that to occur, am I seeing the thoracic vertebrae and the ribs move with it? In her case, no. I can feel that the ribs and the thoracic spine are not moving at the same time I'm moving the lumbar spine. If somebody had a lot of extra tone along the erector spinae, I would try to accomplish this and they would look more like their whole body is rolling back and forth because those muscles are just so tight, they're literally kind of gluing the low back to the ribs, right? One thing I can do here too is take a nice deep breath. All the way out. And do I at least feel my hand at the low back doing something, right? So again. And as soon as I said that, then the diaphragm's activated more. So that could tell you a lot right there for later to breathing. Okay. Hand placements, we've looked at this before. From your pre-assessment, identifying the elevated shoulder, right? You're all doing a great job identifying the elevated shoulder. Does it correlate with when you take them out of gravity here? And then you can feel here. You can also feel here and just see, but where your hands initially were, the ones I showed you, finding that inferior angle, that point, and then just comparing. Great to be able to see that. Now, there's options here too of doing some mobility stuff that feels like massage, where if I stand on this side, it's kind of hard for me to describe, but if I put my palm on the medial side of the scapula, let my fingers come down over that point to the lateral side of it, I can do a push-pull action that moves that scapula back and forth. So I'm standing cross. I'm standing on the right side of her head, moving the left scapula. So I'm reaching across. Yep. Now, as you work your way around, I can continue. I can't always do the pull action, but I can do lots of pushes, and this can feel really good where we're using our palm between the spine of the scapula, but with an intention to nudge that scapula. And then ideally we get to a point where we assess and feel the pliability of the scapula on one side, stand on the other side of the body, and replicate that. And for me, my elevated shoulder, when I try to pull it, it doesn't want to pull back toward me as much. So it's telling me, hey, maybe upper traps and latissimus dorsi are stuck. This is where I can be doing kind of this rhythmic compression. It looks like rhythmic compression on the structures between the spine and the scapula. But the added piece I can be capturing with this is, what is the scapula doing, right? Okay, we've also identified elevation, depression of the scapula. Let's go to the neck. We can always ask the client, all right, can you lift your head up and just turn your head one way and rest your cheek? Good. Okay, go the other way. Okay, good. Back down. And then if it seems scary, right? Yeah. That would be a cautionary one. I'm not very prone to doing that in this position. Sandy, you saw, for example, like turned my head and was massaging. I really would tell you to be cautious, especially if there's neck-related symptoms. You're better off waiting until like supine for rotation-based stuff with the neck, right? But you could, but if it's restricted, yeah, don't just keep doing it. Okay, to the shoulders. Now, they can pick their head up and that's hyperextension. They're in essentially outside of the arms. They have to turn the palms over like this, but this would be anatomical position. But we're going to be internally rotated at the shoulder and pronated at the wrist and forearm when they're laying like this in traditional prone. If we take the arm off the side of the table, what motion have we done to the shoulder? They are in extension, they're in anatomical position. If I do this, if I go out to the side, but I call that abduction, but I call that extension, abduction. So that's abduction to at least a little bit more than 45 degrees. If I grab that arm and just kind of, as I adjust it, like I help guide a person's arm here, and we can take it right to about 90 degrees. So I can assess 90 degrees of shoulder AB, abduction. And then here too, we can quickly look at external and internal rotation. So there's external rotation. Now stabilizing hand, I'm holding above the joint, proximal at least to the elbow here. The table is helping stabilize the shoulder for me right now. But then right there, external rotation versus internal rotation. External rotation, slightly more, feels more limited here. Less limited here. Okay. Now, there's elbow flexion, but the table would be in the way for me to increase that. Might be able to do a little bit more, but elbow flexion at least 90, a little bit more. Extension, the one place where there's an appropriate hard end feel. Great. If the arm is up over top of the table edge, like this, then we've taken it even further to almost to that 180. So, all right. Arm back down. Wrist stuff, real easy, right? Wrist flexion, now stabilizing. Typically that was a case where you felt me flutter because I was like, I'm not actually stabilizing above the shoulder, but oh well. Here, stabilizing above the wrist, proximal to the wrist, superior to it. There's flexion, soft end feel, If I take the arm off the edge, extension, soft end feel. At least I hope that's what we're finding with everybody. Great. Individual fingers, you know, we can think like that, but I can go a little bit, I'm just grabbing each one. Confirm we can get the full extension. I could do this in prone, it's not my preferred. I would wait with like the finger and most of like the specific wrist stuff for supine, but you can do it here. No reason why like all of this doesn't get sprinkled in where I'm doing massage. I'm like, oh, wrist flexion's good, wrist extension's good, and I'm just going right into my massage routine. But snuck in there is all this assessment. Okay, swoop around, compare the other side. Rhythmic oscillation of the shoulder is pretty easy here. As long as they can get to this position, you can just roll that humerus back and forth like this. Not very hard work. I can just roll, rhythmically rotate. That can be in itself a really good treatment for any kind of like underlying shoulder issue. And once we're there, confirming external rotation versus internal rotation. Cool. Elbow flexion's already there.
I don't know what's going on.
Elbow extension. What are we finding? Something surprising you?
My shoulder keeps cracking.
Oh.
And that's not like normal, I don't think.
Some underlying crepitus is normal. Doesn't hurt, right? Are we getting a pop that hurts? Okay.
No, it was just like different.
You do, when you're going through ranges, don't want to just keep on going into pops too much. But a regular-ish, like, yeah. So here, this wrist feels like it has a little bit more range compared to the other one. I could assess fingers and the metacarpals here, but I tend to wait for supine for that. But there's no reason why I couldn't like grab each individual carpal bone and say like, hey, Ken, does it feel like so it starts, your thumb or your big toe is 1 and it goes to 5. So I go, is the first and the second moving okay? Is the second and third moving okay? Third and fourth moving okay? Fourth and fifth moving okay? All right. Is that comfy for you here?
Yeah, that's fine.
So you can see how that's sprinkled in. It's like, here's my routine, going through the massage. I'm here, moving the scapulas, feeling how they're moving, positioning the shoulder, rolling it back and forth. All right, and just like all this joint assessment stuff can be melded into the massage rather than made like its own separate thing, even though we're doing it right now as its own separate thing. Okay, next one, the hip. Bending the knee. Stabilizing at the pelvis. I stabilize right on the sacrum, and then we're going to do the rotation. We've practiced this one plenty. And then we're looking for 45, 45. Oh, a lot more this way. So I'm limited in, if I go this way, this is external rotation, limited in external rotation, lots of internal rotation. That would be less common with low back dysfunction. So I'd have to figure out if there's a symptom in play here, but typically people will have much more external rotation versus internal. But that tells me something. All right, now we're right here for the knee. So knee flexion, cool. No hard end feel. Hip, always reinforcing for you. Outside of the elbow, no hard end feel, okay? There's resistance, but it doesn't feel like I just hit a hard stop similar to the elbow. Worthwhile at the knee, just kind of confirm, like, yep, a little spring. Okay. And then we're right here for the ankle too. So ankle, dorsiflexion. And what I want to feel, doesn't matter how I do it, but if I set their leg, their foot in such a way where like this is flat with the horizon, I want to be able to get at least a few degrees the other way, right? So this is the way you'll see a lot of people at least do a stretch. So this will begin the story of how we could take the joint range of motion and mobility stuff and take this to a stretch-based routine. I tend to say as a massage therapist, like stretching isn't necessarily something you need to do a lot of. You can do more massage coupled with joint movement and get just as good results. But if I want to stretch the Achilles and the muscles that become the Achilles, then this is a very body mechanics efficient way, where I just hold the calcaneus. We have shoes in the way, but that's okay. And then just drop my forearm. So we increase dorsiflexion, thus stretching the muscles that would cause plantar flexion. And that's usually the one that needs encouragement. And then seeing how the plantar flexion is, I'm like, okay, that's pretty good. Shoes will get in the way, where like I actually don't want to do force further because I'm just going to crimp the Achilles with the lip of the shoe. So let's compare the other side. Go around. Hip. At least I am symmetrical, so this may just be normal for this client. I'd want to identify that it looks like, because we have too much internal rotation, that I would want to maybe make sure I target and work a bit on the internal hip rotators, like tensor fascia lata. Okay, knee flexion, looking pretty symmetrical, good. Ankle mobility, plantar flexion, going into dorsiflexion, and not too bad, pretty symmetrical. Other ones we could look at here would be inversion, eversion. You could do those individually, or as a person's laying here like this, you can get kind of more of a, you want to watch because we're not able to stabilize above, right? So I'd have to watch that I'm not moving it so much that there's a distortion occurring at the knee. But it's like, can I get their heels more or less in the same plane, or does one feel a little, seems like there's a little bit, nope, now everything freed up as I went back and forth a couple times. Just seeing how does that compare, right? And how that could sneak into a nice foot massage of like, here, grab that heel, nope, that's moving good that way, this one's moving good that way, on and away we go. The next one I'm going to show, I would tell you to be careful if there's something going on in the lumbar spine, okay? Taking the hip into hyperextension like this is just, it's a semi-cautionary thing. Whether you, in the future when we're asking people to do a muscle action where they're lifting their leg up off the table, or we're doing stretching, I just want to say, if there's lumbar issues, be careful and maybe don't start off with that, right? Because you can be thinking you're just stretching the hip, but that could be increasing lordosis and cause some stress here. Now, it isn't perfect, but I could turn this into a little bit of a stretch for the hip flexors, maybe even the knee extensors. And it depends on the table height and ratio. If you have a step stool, that might be able to help you. But one trick I have is I just need to lift their leg up and I stick my knee underneath their knee. Maybe it looks like they're able to pull that off okay. And then if I increase the knee flexion, that might take us to a bit of a stretch. So, any stretch?
A little bit.
Little bit.
About it.
Yeah.
My upper quads.
Now, I don't feel like she needs the stretch. I don't think this client that would make sense to do, right?
tight, so I'm not feeling a stretch in the flexors.
So hip flexors or knee extensors, both of these could be one. Now you could just, if the quads are really tight, you could just do this and have it end up being a stretch. But coupling the two together works pretty well. What you might see other practitioners do is a more aggressive, like grabbing the leg and trying to really lift the hip more into hyperextension. I would tell you, don't put yourself through that. It's just not going to be good body mechanics. If you can pull it off with brute strength, great, but it's not usually required.
Your lower back raises up with this one.
Is it?
So yeah, good identification. So Andrew's saying took the hip up into hyperextension, and he saw the back
Raise up.
just raise up too. So we know there's something, but ideally what it probably means is hip flexors are tight. So rather than the stretch, this can be a way to go, oh, there's that. I would tell you our best work tends to be in using this joint range stuff even to stretch as an assessment tool to know what to massage and work on more. So that we're in this position, I'd be like, okay, great, when you're in supine, I'm gonna get those hip flexors.